guest today is Dr. Rick Fessler, who is an internationally renowned spine expert. He is professor of neurosurgery at Rush Medical School in Chicago and is also on the faculty at the Chicago Institute of Neurosurgery and Neuroresearch. Welcome, Dr. Fessler.
Thank you, Jeremy.
Thank you for being here today. Dr. Fessler is going to be explaining to us a little bit about microendoscopic surgery for the spine. It's a lot of long terms. Could you explain to us what is microendoscopic surgery?
Yes. Microendoscopic surgery is a new surgical technique that we've been developing over the last 4 or 5 years. It can be thought of as the next generation of surgery for spine problems, essentially. What it is doing traditional spine surgery, but through much smaller incisions, using an endoscope to see our surgical field, rather than our plain eyesight or a microscope.
And for those of us who aren't familiar with some of those terms, what's an endoscope?
An endoscope is a camera, in this case a very small camera, that we can put down into the body to see the inside without having to make large incisions on the outside.
Okay, so in summary, the main difference between a microendoscopic approach and a traditional approach would be?
The major difference is that, for example, 15 years ago when I learned how to do routine spine surgery, for a simple herniated disc, we would make a very large incision, perhaps as long as 3 or 4 inches, in the middle of the back and dissect all the muscles off the spine. So we could expose the entire area that had a herniated disc. And then we would, in fact, operate on only a very small area. At that point, the use of the microscope for surgery came into play. And that allowed us to decrease our incision to perhaps 2 inches long, even a little smaller sometimes. But still we had to dissect all the muscle off the spine so we could get down and see the area where the herniated disc was. With the microendoscopic approach, our incision in the skin is 2 centimeters long or less, and there is no muscle dissection whatsoever. The difference is that we put in a small pin and then a series of dilators over the pin so that we spread the muscle fibers apart but never cut them. Once we're down to the area where we have to do the operation, our surgical field is really the same as it was even with the large incision, and we're able to see very clearly what we have to do to get the job done. So we can get there now and do the surgery, but without disrupting all the muscles, and that's the big difference for the patient.
Okay. Now I think minimally invasive surgery has probably been around quite a long time. Is the microendoscopic techniques that you're describing, is this a step forward over previous endoscopic techniques?
We haven't used endoscopic surgery a lot in the spine until the last 4 or 5 years. Certainly, endoscopic surgery has been around in general surgery for quite a long time now. And what we've done is we've adopted many of their techniques for the spine. This is slightly different, but it's still an endoscopic technique. When we first started developing endoscopic techniques 10 years ago, some as long as 15, we were using different approaches with very small cameras, but our limitation in those procedures was that the instruments we were able to use to, for example, remove a disc were too small to get it done effectively. So although we could get to the area where there was a problem, we really couldn't take care of the problem well. The difference between the new technique and the older technique is that now when we get to the problem, we can use our standard surgical instruments to do the same operation we've always done, but we just don't have to destroy everything on our way to get there.
I see. Now what type of condition of the spine would this be suitable for?
Initially, when we designed this, we were only using it for acute, that is very recent, herniated discs in the low back. As our experience has developed over the years, however, we now are using it for recurrent or second herniations at the same level. That is, we're able to now dissect through the scar even and do a much more difficult case than we were able to do initially. We can also use it now for problems such as lumbar stenosis, which is an aging problem where the bones and the ligaments get so thick that they squeeze our nerves and they hurt and prevent us from walking and impact our daily lives. That is a very large open procedure with incisions 6 to 8 inches long frequently. Complete muscle dissection in order to remove all of the bones in the area compressing the nerves. We can now do this endoscopically through that 2-centimeter incision and not dissect any muscle. The difference to the patient is staying in the hospital 5 days versus going home the next morning.
It's a big difference for patients. A lot of patients are probably hearing you say this and they're thinking, well, I've got back pain. How would they know if they're a suitable candidate for this type of procedure?
Well, that's a great question, because the different types of problems we get in our back have different ways of telling us we've got a problem. Patients that have herniated discs and are good candidates for this are patients who have not been operated on multiple times previously and who have severe leg pain or buttock pain more so than just back pain. Back pain does not respond as well with any operation we do if you have a herniated disc, but the severe leg pain does. Now, patients who have lumbar stenosis are a different type of patient. They are the older patient whose bones and ligaments have thickened and who have gotten progressively worse over a period of years, to the point where now they can't walk so well. And those patients are very good candidates if they've got even back pain as their primary complaint. But very often those patients also will have the pain that shoots down into the legs.
And as always, they should obviously refer themselves to a specialist who addresses spine surgery to discuss the new technique. Are there a lot of surgeons using this technique across the United States?
There are more and more every day because we're training more people to do this. But the average neurosurgeon so far does not do this, or the average orthopedic surgeon. It is primarily people who have an interest in minimally invasive surgery and have spent the time to learn the techniques. But every day, more and more people are learning it, and I think that in 5 years, it'll be the common procedure for low back problems.
Okay. Sounds like a very important step forward within the treatment of spine conditions. I'd like to thank you very much for your time.
Thank you, Jeremy.
Thank you.